A very good evening from the Empower T1D team as well as the Tie Up team. Today, we will be having a very special webinar episode on behalf of the Empower and the Tie Up community. I am Dr. Amit Kumar De, one of the founder member of the Empower T1D community, and it will be my privilege today to be moderating this session. So, dear folks, as we all know, that type 1 diabetes management can be often very challenging, even in the best of circumstances, in the ideal circumstances. But situations in our practical lives are not always ideal, and especially when resources are limited, whether it is due to economic, geographic, or even healthcare access barriers or communication barriers, these complexities become even pronounced. So today, our focus will be on how to provide uncompromised care for the T1D patients, even in low resource environments. I think this is a need of the hour topic, and it's a critical conversation, especially for countries like India and other parts of Southeast Asia and in other parts of the world where resources are often stretched, but at the same time, it demands the need for high quality diabetes care because everyone deserves the right to the right quality of care. And we have two very renowned individuals who have done fantastic work in this field of type 1 diabetes care. And it's my honor and privilege to welcome Dr. Shujai Ghosh, a renowned endocrinologist from the city of Joy, my city, the city of Kolkata. Dr. Ghosh is a person that needs no introduction. He's a DM endocrinology. He's an international advisory board member of the endocrinology section in Davidson textbook. He has held multiple positions in the leading organizations across the country. He's worked as a clinical faculty at the University of Glasgow. He has several publications and several awards, but most important is the ground level work that he has done, the fantastic work he has done in providing T1D care to resource limited individuals in resource limited settings with a very practical approach. And we are very happy to have Dr. Ghosh with us, who will be taking his journey, his experience, and his project, which is quite famous across the globe now. And we are proud to have this the West Bengal model, as it is called. And this is always going to be a landmark model, and it is going to be a source of inspiration to many to follow, and he's going to talk about that and how we can improve T1D care to the best of our abilities, even in resource limited settings. Our second speaker, of course, is going to be the founder chair of the Tie Up community, a person who needs no introduction, Dr. Archana Sada. But we are going to come to her content and her topic after the session by Dr. Ghosh. So now I'm going to hand over to Dr. Sujay Ghosh for his session. A warm welcome, Dr. Ghosh.
Thank you, Amit, for that very kind introduction. And I think I'm very happy to be part of this program that you are organizing today. Let me try and first share my slides. Hopefully they are
Yes.
visible and I'm audible. Let me just put it onto full screen.
Absolutely.
Right. So I'm going to essentially talk about how we have tried to deliver type 1 diabetes care in a government setup. And I'm assuming that Archana ma'am is going to talk about her model of care, which she's currently working in a non-government setup, but we had a discussion that she's going to involve the Jilla Parishad and others as well, because we all realize that whatever we are doing, it needs to be a sustainable model rather than working as individuals. So Dr. Amit already spoke about a couple of things, and I'm going to actually talk a little bit about the challenges of type 1 diabetes management in low resource settings like India. Of course, in terms of the economy of the country, we might be the fifth largest GDP in country worldwide, but when it comes to per capita income, we rank 119 in the world. We spent less than 2% of our GDP on health, and education and awareness is pretty pathetic. Infrastructure is not geared for type 1 diabetes, and there are several challenges related to diagnosis and management. And apart from the basic care, nobody talks about behavioral issues and psychological issues in type 1 diabetes. So if you're looking at diabetes per se, and if you're looking at the national health policies that we've had for management of non-communicable disease, this is the kind of journey that I'm trying to show you. 2018, you had Ayushman Bharat, and And then you had the National Program for Prevention and Control of Cancer, Diabetes, Cardiovascular Disease, and Stroke, which last year got renamed as the National NCD Program. Now, if you actually go on to that National NCD Program and try to figure out where type 1 diabetes figures, you will find that it is mentioned twice. Once when it talks about the types of diabetes, and in the glossary, which actually refers to that reference of types of diabetes. So, as of now, there had been no initiatives taken for management of type 1 diabetes as far as the government of India is concerned. And there are several policy gaps in type 1 diabetes management. So, first of all, you got no basic service or a health program for type 1 diabetes. There are some states that are doing their bit. For example, Kerala has a Mithai program, Chhattisgarh has a Bal Madhumeha program, and Tamil Nadu has a Bits and Pieces program. But the rest, like Rajasthan is taking initiatives, Madhya Pradesh is taking certain initiatives, and Gujarat has taken certain initiatives. But what we essentially need is we need to ensure that there is continuous supply of insulin, syringes or pens, glucometers, strips, medical care, emergency support, because it's common experience that nobody wants to look after a child or an adult with type 1 diabetes when the person is ill. Everybody is shaky. At least most doctors are. They will say, leke jaiye, kahin leke jaiye. So emergency care is something which is bad. There is no kind of financial support. Only recently we managed to convince the government of West Bengal that up to A-level education is going to be free for all children with type 1 diabetes. What about employment? What about insurance? What about jobs? People, the moment they hear you've got type 1 diabetes, no one wants to take you. And there is no concept of diabetes education in India at this point of time for adults also. Whatever the force of diabetes educators has been created has predominantly not been created by the government, but by non-government organizations. And I already told you there's no program to support prevention and of complications, discrimination at work, and no program for an awareness for preventing social discriminations. And this is one paper, I've actually not quoted the full paper. This got published less than a month ago from Dr. Madhu's center, that is the UCM Delhi. And this is part of the ICMR Young Diabetes Registry. And it has about 800 to 900 children. And over a 6.5-year follow-up in that study of the ICMR center in Delhi, more than 11% of the kids had died. And the commonest causes of death were supposedly infections and ketoacidosis. So that's the state of affairs in tertiary care hospitals in India. 11% dead in 6.5 years. Now, when we are talking about levels of care, I'm not going to try and talk about, the 780G, the artificial pump with the algorithm and things like that. I'm going to only talk about the yellow level. That's the intermediate care. And I'm going to talk about that we are going to provide basal insulin in the form of glargine, 3 shots of either human regular or analog regular rapid-acting insulin, 3 to 4 tests per day, and HbA1c at least 3 times a year, if not 4 times, basic anthropometric care treatments as indicated, minimum level of diabetes education, support by a dietitian, a nutritionist, a diabetes educator, and camps to be held every now and then, preferably every 3 months, and some kind of support in terms of the emergency care. Now, if you are able to do this, it is estimated that your A1C will be somewhere around 8 to 9, and you will cut down on the mortality and long-term complications of diabetes to a great extent. At this point of time, the average lifespan in India for someone diagnosed with type 1 diabetes at age 10, the lifespan is 29 years. That means 40 years of life is lost currently, according to estimates. So that is how bad we are. Now, it's not that we don't know what needs to be done. We are quite aware of what needs to be done. The problem is implementation of knowledge. So that's where implementation research comes in. So we thought of that we will have a structured model which could be escalated into a national program wherein the medication would be provided, monitoring would be provided, counseling would be provided, emergency care would be there, and there will be a national electronic registry as well. And these would be the components of the care. Timely diagnosis, which is because I think Even now in India, whatever the estimates might be, I believe it's at least about 20% of our children never get diagnosed with type 1 diabetes. They die undiagnosed. Case management, which would include glycemic control, blood pressure control, lipid testing, thyroid screening, annual screening for complications, including the eye, the foot, the kidney. Preconception care, something often forgotten. I have quite a few of our patients now who are proud moms of children. There has to be structured diabetes education and maintenance of a national registry. So this model has to be something which is easy to implement. It has to be scalable, it has to be replicable, effective, and in line with the currently followed other national non-communicable disease adult program. So with that in mind, we first launched this model in 5 district clinics of the state of West Bengal. And this is the logo of our childhood type 1 diabetes clinic. And we established a dedicated type 1 clinic once a week in each of the currently existing adult NCD clinics to cater to people living with type 1 diabetes. And this is the kind of framework we tried to follow in establishing each of these clinics. First, we would have a sensitization program, and I'll talk about each of these as I go through. So the sensitization program, we identified human resource in that particular district hospital in that clinic. One would be an MD physician and the other would be an MD pediatrician. We've not thought of an overlap clinic because we wanted a continuation of care in the same clinic, whether you're a child or an adult. A nurse whom we trained up, particularly to keep stock of things, dispensing, some amount of education, the NCD counselor to educate the patient, a data entry operator for the registry, and we also made sure that we assessed the existing NCD clinic to figure out what problems were there or what we needed in terms of other resources. So I've already talked about assessing the resources that's normally supposed to be there in an adult NCD clinic. Trust me, the government of India states that there are 734 NCD clinics for adults. In India, I was recently there in one of the hospitals in Midnapur, which is a medical college, which does not even have an adult NCD clinic. On paper, it is supposed to exist. And then we use the adult NCD diary, which we kind of reworked into a type 1 diary, keeping the same format as you would have in the adult. And we created SMBG logbooks, letters to schools in local languages, IEC booklets in local languages, monthly formats, summary formats, and all of that. And we developed a web-based application through which every patient's data would be kept as well as would serve as the electronic registry. And there would be generation of e-prescription. We ensured that there is completeness of data and most importantly, stock maintenance, because you cannot afford to have a situation where your clinic runs out of insulin. So remotely, I can monitor each of the sites to see, how much of insulin stock we have, depending on the number of patients. How long is it going to last? We make sure that we have stocks well in advance for at least 3 months, because you know how the procurement process in government hospitals can often be. So we started off with a day-long training program at the state level with these individuals from the district hospital that I talked about. This is one of those day-long training programs. And then we had an initial visit in these NCDs clinics, initial supervisory visits. We found out whether they had registers, physical infrastructure, whether there was trained human resource, equipments, particularly, for example, a small cuff for blood pressure measurement in children, drugs and consumables. And we made these checklists to figure out what's there and what's not there so that these could be put into place before the clinic started, and including the trained human resource and the equipments, the drugs and consumables. Now, we separated out the pharmacy of the clinic from the main pharmacy of the hospital, because this is a dedicated clinic where we cannot run out of supplies of drugs, and where stock keeping as well as purchases and everything has to be done within the clinic itself. And supply chain maintenance is very, very, very important. So you can see in one of the refrigerators in one of the clinics, this is what the supplies are like. And then we went to the center after they cleared the initial checklist to say that we have everything that we talked about. And we reassessed whether all of that was in place. And we again had an online on-site training, interactive sessions, discussion about practical aspects, including we wanted to check whether the human resource had actually been adequately trained with pre and post training knowledge assessment. An initial line list of patients was created. Even when we decided upon a site, we said, okay, everybody that comes to your hospital with diabetes in young with type 1, which is possible, you have to start making a register, which was from the pediatrics ward, from the adult medicine ward, from the general emergency, and from the OPD. So you already had a list. Now, once the clinic has started working and we are confident that, the clinic is doing well, we have gone out and actually spoken to at every level of healthcare in that district, including training of grassroots health workers, the ASHA and the ANMs. And perhaps that the ASHA worker now is being given a tab to collect health-related information at doorstep. To that, we are currently adding a new CBAC form specifically for children, which will help us to identify newly diagnosed type 1s and will also help in referral of currently existing and all newly diagnosed type 1 to this particular clinic. So after the clinic initiation, we have decided on hand-holding for at least 1 year by a trained adult endocrinologist who would just go and sit there in the clinic and not see patients, but would address every issue that every individual healthcare professional has in that clinic while trying to look for or looking after children with diabetes, excuse me. So this is one of the district general hospitals where, excuse me, we've set up a type 1 diabetes clinic. And at 3 to 6 months interval, we are holding camps, and I'm hoping that Archana ma'am, we had a discussion, we'll be able to structure it even better with the resources that she has been using to talk about all of the issues related to management of type 1 diabetes. So these are the things that we normally do: enrollment, anthropometric measurements, history taking, management of disease and complications, laboratory tests, dispensing of insulin and other consumables, patient education, monthly monitoring, daycare facility, emergency services, and timely referral to tertiary care hospitals if needed, and data keeping and stock maintenance. So this is what our Barashat clinic. This is the initial ID card that's provided. These are the anthropometric tests that we do. Management of disease and its complication. These are the issues that are taught. These are the laboratory tests that are performed. These are the insulin, medication, and consumables that we provide. This is the educational material that is provided to the children and their families. Monthly monitoring for children is mandatory, and daycare facilities if required, and hospital admissions as well if ever required. Timely referral, particularly in case there are certain issues that are flagged up. Data keeping and stock maintenance is something that I've already talked about. And at the end of 1 year, I'll share with you some of the data. So about 40% of our kids actually came from below poverty line. Their family monthly income is around 7,000 rupees. And most parents and caregivers, more than 70%, had not even completed primary education. To start with, when we started these clinics, about 60% were on basal bolus. After 1 year, 100% are now on basal bolus insulin. The insulin injection site was unhealthy in about 20% of people at the start of the monitoring. It's now improved until almost 98%. At least 2 tests a day is now what they are doing, where in the past they were only doing it 2 to 3 times a week. And majority of our patients are now self-injecting. You've got to remember that about 15% of our children are below the age 7. So they are the ones, some of them are not taking it themselves. And the HbA1c, if you look at, it's come down by about 1% in 1 year. The fasting and the post meals have improved as well. And in terms of the complication rate, ketosis is 0. Hypoglycemia reported has come down. Infections is 0. Hospitalization is 0. And death is 0. In terms of evaluation of psychological well-being, that's improved dramatically in terms of diabetes-specific health-related quality of life. And all of those sub-evaluation points that we are talking about, they have improved. General well-being has improved. Family functioning and social support has improved, because it's when you're managing type 1, it's not just about the child, but about the entire family. And the health-related aspects, the well-being, and the functional, we've re-highlighted that these are the dramatic changes that's happened. In terms of the expenditure, look at the bottom line. What was about costing 3,500 rupees per month per child for a family has come down to 416 rupees at the end of 1 year per month. So where are we going from here? We've written up a article in Lancet which talks about the model of care becoming the foundation for a national health program. We've published the methodology of our paper. We are actually in the process of publishing the results of our paper. This is the government of West Bengal, which has actually then given us permission to go ahead and expand it to another 10 districts. So these are the other 10 districts that we're talking about. And the state of West Bengal has given us the award that this is the best public health program in the state of West Bengal at present. The central government has created a committee for a national health program of childhood NCDs, and I'm one of the members on that team. And the national program is being built based on our model. And I'm part of the technical expert group for diabetes in children by the central government, and that's the document which is waiting to be released very soon as the National Program for Prevention and Control of Non-Communicable Diseases in Children. So this week, both Dr. Archana and myself, we were at ISPAD. And the other thing that's coming up is that in DRCP, IDF is coming out with a document of sailing 7 seas of type 1 diabetes advocacy with 5 models from 5 continents. Ours is the model from Asia. The document is supposed to be published in April of next year during one of the sessions at IDF Bangkok on type 1 diabetes, where I'll be a part of it to present our data. Our other funding agencies and supporting bodies apart from the Government of India and Government of West Bengal is Breakthrough Type 1, previously named JDRF, UNICEF Global and UNICEF India, WHO and WJ Clinton Foundation, a Clinton Health Access Initiative. So I shall stop there for the next session.
I think in one word, it's an amazing initiative. It's a fantastic the whole lookout of what you've done, the whole project in 1 year, and the whole integration, interoperability. It's fascinating. It's something to take forward. So we'll have some questions coming in, Dr. Ghosh. Thank you very much for sharing the data, for sharing the insights with us. So we will now move on to person who needs no introduction, Dr. Archana Sada. Of course, the founder of URAN, that is nurturing, that is guiding about 1,300 T1D kids for a lot of years, I presume now, and she has of course contributed in the ISPAD guidelines of managing T1D in low resource settings. So now Dr. Archana Sada is going to share her point of view on how we can manage type 1 diabetes in low resource settings with the best of care. Dr. Sada.
Thank you, Dr. Amit, and thank you for having this session, a very, very important session that both Dr. Sujoy and myself feel very passionately about. And it's so nice to see all of you joining that bandwagon of passion and commitment to the cause of type 1 diabetes. First of all, let me tell you that for Dr. Sujoy and his work, it is absolutely amazing. And it has become a trailblazer of how one can actually do it with the governments. So I'm going to give you the other side of exactly the same coin. I think the passion is the same, the intention is the same, but here we have a government kind of a very structured setup. And what happens when that was not possible? When I started 25 years back, when these things were not possible, when I was not in a public government setup, and then when we tried to do this, and I'm going to actually talk more about what can anyone who is today wanting to do something, not in a government setup, but say in a private setup, in your own clinic. And as I used to feel earlier that it is not possible, I will not be able to do it. And I used to feel very inadequate because there were no resources, and I wanted to give the children the best and always felt I begged, borrowed, luckily didn't have to steal, and went to the government medical colleges, went to ministers, went to so many places, but it didn't really work out that way. And of course, now with Dr. Sujoy having set the path blazing in Kolkata, so now we have a model that we can replicate, and now we are also looking at that aspect. But I'm going to now talk about all the other aspects for every clinician in the country, every NGO in the country, every type 1 support group in the country who is working for people with limited resource setting, and how can we go ahead. So my first principle that I work on in type 1 care is improvise, not compromise, right? So we want to give the best. We don't want to compromise. And yet, how do we give the best when we have less resources? We improvise. India is the land of jugaad. We can do anything. So we are capable of finding a solution where none exists, very innovatively with a lot of improvisation, provided we want to. So that is my thought. Wherever there is limitation, where there is something less, there we can have an improvisation of the system to get rid of that limitation and yet provide a non-compromised care. May not be the ideal care, may not be the level 1 that Dr. Sujoy showed, which we are all striving for, but it will give us outcomes that are very close to that and way better than where we are today. So I'm going to start with a very simple aspect of diagnosis, because when I started, I used to feel inadequate that we cannot do antibodies. I don't have the money for C-peptide. Is this really type 1? This is not type 1. Do I really need to do all these tests? So all those thoughts kept on going in mind. So at a low resource setting, let us improvise and let's talk about people across the globe. And this is a discussion I've had with all the leading you can say scientists across the country working in type 1 space. So right now, clinical symptoms raised with raised blood sugars are enough to label them as type 1, start treating with insulin therapy, because we are looking at it clinically and we have raised blood sugar. So I'm not going into details. I'm just saying that that's enough, because that's a doctor who's going to diagnose. They know what the clinical symptoms are. Recheck the blood sugar is something I will guide, because sometimes if it's just one glucometer reading or one lab reading from the village, it could go wrong. A sample could be changed. Something can happen. So please check once again in a laboratory and then start. Confirmatory tests can be done later once the child settles in, may not be done, but can be done, especially if there's a suspicion or doubt in diagnosis, which would be there, because sometimes, there are so many types of childhood diabetes. But a small percentage of these people you feel clinically are type 1 and have started on insulin will turn out to be non-type 1 diabetes. It will turn out to be non-T1D. There'll be a very small percentage later. But that's okay, because if we are making a mistake, it's better to make a mistake on the side of using insulin, because that will save life. That's not going to harm somebody. And maybe a small percentage will turn back and say, okay, this doesn't look like type 1 diabetes. Let us investigate. Then it's worth investing, and then would be not type 1 diabetes, and therapy would change. Nobody's going to be troubled with that. The beneficiary is going to be very happy, and we have not erred by not starting treatment in time, especially when they come in hyperglycemia with high HbA1c, glucotoxic symptoms. No matter which the type of diabetes is, anyway, they need insulin therapy. So that's the first part of diagnosis in the low resource setting. Then, as Dr. Sujoy said, that even in the district hospitals in Bengal, with his fight, what did he do? He did not compromise with the type of insulin. Similarly, we begged, borrowed, raised money, did everything, but we did not compromise, because that is something we never should compromise. So it has to be a basal bolus regime. There is absolutely no other story. There is no if, but, school, not willing, doctor, availability, because everything can be made available. If you're looking at only money as the limited resource, it is available in the generic store, 340 rupees for Glargine and 75 rupees for regular insulin. Please check the cold storage. If you are in a town and you're going to refer them to a certain generic store, please check on their cold chain maintenance. So far, I have found that they do a very good cold chain maintenance, but it's always good to confirm. Now, as we are talking for mostly the doctors here, Pharma companies are very happy to give you. Just ask, beg, so many things they're willing to do. They are always asking, can they help in some way or the other? That's something they can give absolutely at low cost or free. And that we can pass on to the people. NGOs, suppose you appeal to Udan to help you with insulin, I would be able to, but I would need proper documentation. So if you are an organized person, an organized organization, you're willing to give the documentation required, any NGO will be able to support you as well. Before I formed the NGO and before I could get any funding, I had all my relatives, my uncles, aunties, cousins, brothers, everyone, and everyone had to contribute on their birthday. So the only thing they were allowed to do on their birthdays and anniversary is they had to adopt a child's therapy, either for a month or for a year. So there's so many things, we have people have a birthday party, spend 500 rupees on what? A big Starbucks coffee or something. Just motivate them, give them some. And it works. It becomes like a chain reaction. So many of our children with type 1 diabetes have engaged all their friends on their birthdays and raised insulin for a run. So anything is possible. You have lots of rich and happy patients. Put up a notice in your waiting room. All your rich and happy patients can adopt one child with who is not rich and happy. If an NGO, crowdfunding and CHR support are two great ways of raising funds, and this is something. One advice, one small tip out of experience is, if possible, ask everyone to give you the supplies and not the money. People have a sort of doubt that, okay, if you're asking the money, what are you doing with it? What is happening? Of course, we should have very clear documentation, receipts, feedback. But even then, if anyone says, I want to donate 1,000 rupees, I tell them, okay, give me 1,000 rupees worth of glucometer strips or give me that much worth of insulin rather than giving me the money. It always works very well. They are happy, we are happy. That's anyway what we're going to do with the money. Second thing, which is very important in a low resource setting, is the glucometer, because no matter what, you can't, insulin and glucometer are married to each other. We don't do one without the other. But I am going to ask you all to try to get a glucometer with a memory. If possible, get a connected glucometer, because as I will show you later, how much difference it can make, especially in the low resource setting. Person who is not low resource setting, imagine, and is highly educated. If they had a meter without a memory, without connectivity, they could write it in a logbook. They would have a diary and a pen ready all the time. They would be motivated enough to do it. How do you ask a laborer in a field with a small child, checking their sugar, and she's doing labor? And in between, she's also writing the blood sugar. She may be low literacy. So it's so difficult when it's low. So in low literacy time. So technology is really most useful for people who have low resource setting. And it doesn't come at an extra cost. Actually, glucometers with memory, without memory are almost the same price, or actually the same price. Connected meters are also not, maybe 100 rupees here and there, are not more expensive today. So anyway, we are getting from somewhere. Why not try to get something with a memory, if possible, connected? I don't think any of us should buy glucometers. If you have 50 children, if you have 100 children in your clinic, in low resource setting, make a list. Do not invest on glucometers. They come free with the strip supply. Pharma is always happy to give glucometers free. Appeal to all the people in your town, all the doctors, write them a letter, say, this is what I'm doing. Whatever glucometers you have, please donate. And they will donate it. Every doctor will have 5, 10, 15 glucometers lying around, which they do not pass on to the patient. And this has been my experience, and it works very well. Ask all these Rotarians, Lions, they're always looking for projects. Tell them we have 50 children who need glucometers and a supply of strips, they will give it to you. So approach to right, sometimes we don't know what to ask for. These things are easily done, and they like to donate. I'm with all due respect, but they like to donate. They will take a photograph, post it in their newsletter. We donated this much to this many children. They feel good. We are very happy because it gives something to our children. So do not buy glucometers, buy strips. Strips is something we need to really, really invest on. Wherever you pitch for strips, position sugar monitoring at par with insulin for surviving. Whether it is the government, we saw in Dr. Sujoy's model that even in the district hospital, it was 100 strips per month, right? And insulin basal bolus. So they come together. It is not just, I am giving free insulin. That's not enough. What are you going to do with insulin? How much of insulin are you going to take? So try to make a strip bank, which is what I did when I started. Then 7 rupees is what we get for I'm using AccuCheck Instant, which is the Roche connected glucometer. And because of bulk purchase, we're getting it at 7. You can piggy write another NGO. For example, if you wanted to piggy write Udan, and you wanted to say, I need 5,000 strips every month. But again, if you want to figure out any NGO, you need very good documentation, because that's a key word when it comes to NGOs. Give a clear monitoring pattern and action points. Otherwise, just giving strips is not going to work. If you are giving free insulin, for example, if you're giving basal bolus from your clinic, ask the person to buy 100 strips, bring them, show that he has bought the strips, and then give the basal bolus insulin. So they are spending a little amount on the strips, you are spending the amount on the insulin. But if you just give away the insulin, say go buy strips and do it, they may not buy it. So monitoring is an investment that needs to be made, is part and parcel with insulin, and we have to ensure that it gets done. This is something that came up again and again with Dr. Sujoy's presentation, whether that was the government. This is purely private personal clinic, and that later become an NGO, yet maintaining records is absolutely essential. This is not just for showing, or if tomorrow you may not want to present a paper. It is also for self-analysis. It is also to contribute to rest of the community. It is also to give data to the country when we have our registry. There are so many reasons you need to have, because if you're going to appeal for more funds, it's not going to happen without your data. So that's really important. And if you do not have some fancy softwares, if you do not have that, you can't afford a simple Excel sheet can do so much of magic. Till you go to a bigger point, you just have an Excel sheet and you just keep your data saved. Most of the software that are coming are compatible with the Excel sheet that can be incorporated, and that can be going into that later. All the registries globally also. So start with an Excel sheet, keep all the data, learn, and that is something very basic. I mean, as a doctor, we can all just navigate and self-learn. That's how I learned. You can analyze from it, you can filter from, and later on try getting a good software, because it makes a huge difference. And you can do it on paper in very low resource setting. That's what I initially used to do. Every record used to be on paper once a week. One of the students, in fact, person living with type 1 diabetes, only used to come in, for a very small freelance money, and used to upload all the data onto the software. Now it is done on the go, but that's how it used to be done. So data needs to be maintained at every visit as an absolute necessity if you want to work for the patient benefit, for your organization benefit. This is what we're currently using. This is Clinity. This is called eVaidik from Dr. Krishnan's clinic in Chennai. And it has a model, which is a software for us, but it also has what you can see on the right is a patient app. So a patient has it on their phone. So all the data that we fill up here also goes onto the phone, and the patient can access all the reports. The person living with type 1 diabetes, if they go to another doctor, they can just open up, show their reports, prescriptions, whatever data, everything is in their hand. So something like this really works because it is with both of them. It is not with us only, it is also person living with diabetes has all their data. Next point for any clinician, all of you working in this space, is please monitor their growth. Simple stadiometer doesn't cost anything. Just mark it on the wall, correct it. Please calibrate it once a week. It टेढ़ा हो जाता है, खींचने में आ जाता है, कील नीचे हो जाती है. So many things can happen. Calibrate your stadiometer once a week. A calibrated weighing scale, again check it once a week. Calibrate it. All you need is a height and weight. I mean, it can be as simple as a pencil mark against the wall, but why not to give it a very professional look? Give it a stadiometer and a weighing scale. Use paper growth charts, where validated ones. So you have the IAP charts, the other ones. Otherwise, there's a very simple app on the phone, growth chart app, and you can just put the part and it will create the graph for you and save it. It can be exported, it can be saved. It is a free app. Go to the Google store and you will get a Google. So many simple things can be done, coming at a no cost. Takes a couple of minutes, but doesn't cost much. But record it, analyze it, act upon it, and refer. I understand many will not be equipped to deal with a change in the growth velocity. Please refer. But at least our job at low resource setting is to pick it up. We did not miss it. We could not send 1,000 low resource children to a pediatric endocrinologist, but you could send 10 who did not show appropriate growth for their age, because then they could be looked for other things. So that is a high suspicion of index, and that way you do not miss out on something very basic. Again, this has been talked about in a government hospital, but it's very important in every clinic, all NGOs as well, all support groups who are treating. Please see to it, because people forget to do that for children. get different sizes of cuffs. That's very important. Many places I go to and I don't see a pediatric side BP cuff, and they claim that BP is being checked, and I really wonder how that's being done. The right method, even the automated BP cuffs, these are very simple, low resource, low hanging fruit. Record it, right? And also know the cutoffs appropriate for age. The person doing it will be thinking like an adult. Like, what is a normal blood pressure? So age-wise, make a cutoff, make a chart, stick it on the wall. Let that person know about it. Put the record in the child's diary. So that if they go somewhere else, or tomorrow your data may not be accessible, it should be accessible to them. Check-in every visit is absolutely essential. Check for lipohypertrophy, an absolute essentiality. And Dr. Sujoy showed the change that has happened, and we have witnessed the same change. Do it in every visit. Document it. We have created a scale. I couldn't get the picture here, but we have created a scale which is ABCD, and we grade it every time so that the next visit, we know whether that grade has improved or not. So number, size, in duration, all that basis, it is done. This is something you can train. The person who does it in my clinic is a mother of a child with type 1 diabetes. She is practically illiterate. She can barely read and write, that's all. But she has been trained so beautifully. She knows how to treat it. She knows what to do with it. So anyone can do it. You can train anyone to do this job. Just give them a right training. And while doing it, that's the right time for a site rotation and injection technique, because you're doing it anyway. The checking part, it takes the same time for teaching, okay, where is the injection being taken and how is it being taken, and the site rotation. So we know that lipose itself can be the cause of variability. So do not take this lightly. I get so many people with extreme fluctuations, and all it turns out to be are lipose for some reason which are ignored. So this is extremely important. Coming to the next thing that is of utmost importance in a clinic or in an NGO or a support group, anywhere you're working on type 1 diabetes, is meal planning. So I'm going to talk about at 3 levels. Look at the local staple diet. We cannot give avocados and guacamoles of the world, and that is not chia seeds. These are not the diets that we're going to give. Teach a visually balanced plate. Once they know what is right, what is wrong, teach to recognize macros, because it is, very overrated that this is very difficult. It's not. Once you tell them in some simple words what the carbohydrate, what is a protein, and what is a fat, what is a fiber, they understand it so well. I mean, simple things like above ground veggies, below ground veggies, the difference between the two, 100 grams of what, how much carb, what is zero carb. So it's not difficult. They will be able to pick out. Children in a village would be able to say, Ki, Mama, there is no protein in my plate. I need XYZ thing. Just macros. First is macro recognition, and give them some cheat solutions to balancing. Well, by cheat solution to balancing, I mean that if a child wants to have pav bhaji, how will you teach them? You'll say pav is carbohydrate. Bhaji is made up of potato. It is carbohydrate. Both of them are cooked in ghee or butter or oil. It is fat. What are you consuming? You are consuming this much amount of, say, carbohydrate and fat. What is missing in your plate? Protein and fiber. So if a person did want to have pav bhaji and could have eggs and a salad with it, for example, could still have a portion of pav bhaji and yet have a healthy plate. So you give them a space. This is just an example I'm giving. You can create so many of your own. And these are some of the plates that we teach and they post. And we have a WhatsApp group where they keep posting their plates. They guess their carb count and we tell them whether it's fine or not. Next, and very important, and this is something we're going to work with, as I said, with Dr. Sujoy as well, that once we have given everything, the education is very important. And see, you have your insulin, you have your glucometer. Now you want to take the right dose. How do you do that? So to connect these two dots and make them effective, to bring that drop of HbA1c beyond that, has to be when a tailor-made dose had to be done. And that is only going to happen when finally we learn some kind of carb counting and translate to insulin dose adjustment. These are the two missing links across the country, and this is something we can work on in low resource setting. So once they recognize what is a carb in a plate, motivate them to count. Basic carb counting is just take them to the next step of dose adjustment. What we did was I asked them to have like 100 things in their food. Just 100 things diet. We realized max people, especially low resource setting, they don't have that many things because they're not swigging their food. In fact, it's easier in a low resource setting because they're not having chips every day. They're not having so many brands to eat from. So it's usually 90% is a fixed food. It's 10% when they go to school, college, they have some money. Later on, they have something. So 100 things they eat in a month. Portion-wise carb calculation, help them to do it, create a repository for them, and they keep it with them. They know their food now, and they take it as a reference when they use the insulin shot. So it's like having my own personalized diary. The measures which have to be used have to be my measures. So it is my bowl, my home cup, my home spoon. So that is something that's very important. So if your nutritionist can help them just create this repository of my own food, it becomes very simple. One thing which we have done in Udan is we have asked everyone in Udan eats the same size chapati now. First, we tried to do the carb count of everyone's chapati. Finally, we decided it's easier to teach them that everyone has a 50-gram flour and a chapati made of that. So now everyone knows that their chapati is of 2 carb count. So that has become simpler. So you can improvise. But point is, individualized diary has been created. So then you can move to the advanced carb counting. So first level, as I said, is just a balanced plate. Let them recognize macros. That itself will make them healthy. That will ensure that protein is added, fiber is added. Second is a very basic carb count of things that they have with the bowls, spoons, plates that they have in their own home. Then advanced count. Suppose you don't know how to. I didn't know how to. Very honestly, what did I do? I got hold of Shilpa Joshi in Pune and I said, please train everyone. So she took a series of classes for my team. She took a series of classes for my children, their families, and she handheld us for 6 months. And 6 months later, we were good to go, right? And this was all done online. So you can outsource this kind of learning. We don't always have the skill set, but it's important that we learn, and the teacher can come from anywhere. From basic to advanced is very easy. People get very motivated because they see beautiful results and it gives them freedom. That if you can count your pizza slice carbs, you can bolus accordingly and still get a normal sugar. So it's very easy for people to get convinced to do this. From zero to basic is difficult. Getting them to do it in the first place may be difficult, but the second phase is not very difficult. I know we're talking about low source setting, but I have found a smartphone makes a huge difference. There is internet in the entire country. Phones have revolutionized the medical care in the country in so many ways. And in type 1 diabetes, it works no less. We have a phone bank, people who change models every few years, they donate their phones. There's so many people like that. They just need to know where to give it away. So many things, logging, connected meters, sending diaries. We have illiterate families who cannot read and write, but they can convert their connected glucometer reading into a PDF and send it to us, but they cannot read those numbers. But because they just have to press this button, this button, this button, that's the visual learning. And they're able to send us a PDF of their numbers. This is a illiterate family, right? Because you all know that Aspire hero this year was Lakshmi. How is he doing it? He cannot see, right? But he just does the talk mode and his glucometer is connected and the phone reads out the reading. And here's his sugar is 280, 110, and accordingly he takes a decision. So it can make world of a difference. They're not as expensive as we think. You can get second-hand phones from donation. You can use intermittently then CGMS if it's NFC available. I have kids now buying it on EMI because you can get it on no interest EMI also. There's so many ways. So using a smartphone in the right way. This is an example of that export of the connected glucometer that comes in, and it comes in so easy, and we get all the readings from our kids living in a remote village who cannot read and write or tell the readings correctly. So it's a great investment. I know it sounds fancy, but I think it's very basic and it has really revolutionized the care. Very important factor missing in low resource setting is self-insulin dose adjustment. So at the bottom rung is prescriptive scale, right? Which means the person who does not carb count, you have to give them a fixed carb counted meal plan. That is the mainly limitation because it is a fixed carb counted meal plan. But Our job as the nutritionist educator, we calculate the TDD, ICR, ISF for that child, make a scale for dose adjustment, right? So that includes the correction bonus accordingly. Since the carb counted meal plan is already fixed, so something like this can be written on their diary, that the sugar is in this and this range, add 1, in this and this range, add 2, or can be the dose 5, 6, 7, 8, if they can't even understand. Adding 1, adding 2 can go wrong sometimes. Then you write the actual numbers. So this is called a prescriptive scale. This is not the best idea, but it is a good idea when there is nothing. That is a time where you carb count for them, you create a plate for them, get them into the habit of doing their blood sugar check before a meal, get them to understand that meal remaining the same, the sugars can be different, and accordingly the dose can be different. So one variable is taken care of, the sugar level is taken care of, not the variable of the meal. Okay, so may not be the best final, but something is better than nothing. We go to the next level, and this is something we created, and that is the dosage grid. This was being done elsewhere in the world, but it was not available on open resource, so we sort of deconstructed it and reconstructed it for ourselves, and this is a downloadable grid. So once basic carb count is learned, this can be only done because you have the basic carb count. Then those who cannot use the phone all the time, or because there'll be lots of people, they'll have one smartphone in the family. They will not be having it, one for the child, one for the mother. It is just one smartphone in the family. So there you can just put in your TDD, which insulin is being used. It calculates everything, gives you the grid. And the grid, you can print it, put it on the kitchen wall, print it, keep it in your wallet, print it, put it on your tiffin. You know, all it has is X and Y axis, X axis and Y axis. X axis has the carb counts and the Y axis has the blood sugar levels. And all one has to do is, okay, my sugar is 140, I'm eating 3 carbs, this is the amount of insulin I take. It's tailor-made, individualized for your own ICR. Right? So that is why it is better to do it every 3 months, because TDD will change as the child is growing. It is again not perfect. We know insulin resistance changes throughout the day, sensitivity changes. We know so many cyclical changes, but all those things we can teach, but it works a great level. We found a wonderful reduction in HbA1c, and that is below that 8.5. It comes when this happens. Till then, that is only what we were able to achieve. And final, of course, in people who can carb count, once they learn carb counting, is the dosage apps. Now, this is not low resource setting. Maybe one can say this is advanced, but I find all the low resource setting children advance to this very quickly. Last steps are very easy. It is the first few levels that are tough in low resource setting, because children love technology. If there is a smartphone in the house, they will do this very well. The advantage here, it works very well for small children. So even the lowest resource setting, my village kids, these are the ones that mothers, they find it very difficult to give them the right dose. They give a little more, it goes into hypo. They give a little less, it goes into hypo. And prescriptive is very difficult with a small child, because they're not going to eat just what you have given. So that's where it works very well and gives a lot of freedom, and we can convince them. Fitness, a very important topic, and I will go through this quickly now. Basically, I'm saying you don't always have to have a CGMS. You don't always have to have a pump. Entire Udan does 25 kilometers of trekking, does night treks, does every possible sport on SMBG. So we make our own algorithms, we do monitoring, we do snacking as per carb counting, and do correction policy. These are kids, one is a night camp on top of a mountain. These are other kids who are lined up for the next trek, but you can see they will stop, they will check, they will help others people check. And the plan is made for 24 hours. You have to start from previous night if it is a big event, and continue for afterwards for a possible hypoglycemia. But even day to day, if you understand the physiology, it is possible to create a SMBG-based fitness care plan also. Because if all my kids had to wait for a CGMS and a pump to start running, they would have never run at all. They would have never climbed mountains at all. And all of them do it. Not a single mishap. Thank God for that. Who is going to do all this? Who is going to tell them to do this, that, great, blah, 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 blah. I'm living in a town where nothing exists. There are no diabetes educators. As Dr. Sujoy was mentioning, it's so difficult to get the trained people. You don't have them? Use experiential learning. And these are our demons. People living with diabetes, families of people living with diabetes are the ones who can train them. Get a structured program, train them yourself. They already have experiential learning. They have done it, they have been there, they have empathy, they want to learn, they want to contribute. So just train them. How would kids with the education in a low resource setting, in remote areas, use the local language? Any form of teaching. We have done dances, folk dances, skits, mimes, role plays, videos, posters, drawing activities, coloring books. Do what may you would like in whatever way. Individual teaching is important. Group teaching is also important. It's not an option. Both are important. Physical teaching is important. Online teaching is also important. Just to continue. Use all kinds of and don't hesitate using others' tools. I'm so happy. Whatever anyone makes, I give it to my patients. It's not like only my things. So every child can learn. Onus is upon us to find a way to treat them. I will just give you a tip for anyone who's in low resource setting. If you don't have skilled people, just look for people with kind hearts and willingness to, care, willingness to give. You can train those, but you cannot give a kind heart to people who have knowledge. But you can give knowledge to people who have kind hearts. And in type 1 diabetes, you want people who are empathetic. So give them an incentive, small incentive. They will come for a very small incentive. Need not be financial. It can be name or a post. Make SOPs, evaluation, and feedback mechanisms are very important. Give work as per skill set. As I told you, one of my most low literacy mother is doing the lipo management, and she's perfect at it. I mean, you'll be amazed how good she is. And so best people are those whose lives are already touched with type 1 diabetes, as a parent, as a sibling, as a friend, or already living with type 1 diabetes. So training is easy when people are motivated. Motivating is not easy to trained people. So get a motivated team, train them. And that is very much possible. How will you train them? Train them yourself, evaluate, keep updating, because knowledge is going, just out of the box every day. I learn every day. So I have to train my team every day as frequently as possible. Outsource it. People are so kind across the world. Just ask anyone. If you call me and say, ma'am, will you train my team? I am not going to say no. Call Dr. Amir, Dr. Sujoy, they're not going to say no. Call anyone. People will help you. Try to get certifications for your team afterwards. So all my team, which came just like that, now have NDAP. They have done their best. Many of them have done the ideal. So whatever courses are available, they are trying, right? So it's a huge outcome with a very small investment. There are very, very good courses available. Create your tools, be it in whatever way, and not go into them. Peer activity are a game changer. Unstructured structure. So when kids come to RAN, we realize what changes them is not all this that I had talked about. It is seeing other children with type 1 diabetes. So we plan a thing. So these looks very structured, that everyone is dancing similarly, but it happened so-called spontaneously. It wasn't a dance class. We planted a spontaneity in the dance. And then one of the child leads it and they do it. And that empowers them more than anything. They then listen to your carb counting. They then listen to everything else because they feel good about themselves and about their community. Storage, I think everyone knows about it. Just find out the need and please give those options. Motivation, as Dr. Sujoy was talking about, we don't focus on mental health. Motivation, these are absolutely important. What worked for us was clubs. We need that. So we have a dance club, cricket club, we have a cricket team, trekking team, we have a literature club, a theater club, and whoever has whatever interest, they get together. There's a walk with your dog program where my kids will walk with me in the university. So anything which is not in the clinic, which is not talking about sugar, that is something that will make them motivated to come back and take care of the sugar, because if you want to climb a mountain, if you want to dance, you want to do theater, you want to have a great blood sugar level. So that's a great way of motivating them. Psychological well-being is a huge challenge. Do not ignore it. If you can't handle it, outsource it. We outsourced our kids' well-being and their parents' well-being to a group called WISA, which is an online global mental health care unit. And in fact, they were so kind that we have now collaborated with them and they have created a support system for us in Marathi. It already exists in English, for the whole globe. The NHS is using it, the Singapore government is using it, but it's India-based, and we finally got it in Marathi for our kids, and it has made a huge difference. Children say, when my father is alcoholic and he's beating my mother outside, I am on Visa, chatting with Visa and asking how to cope. And Visa is so non-judgmental and talks to me that I feel secure. I have a friend in my pocket. This is the kind of feedback we get, and they feel safe when there is a war going on in their own family. And this is something in low resource setting becomes extremely important. Last few things are the inter-visit communication. There has to be a place. So we have these WhatsApp challenges, groups, quizzes, prizes. There has to be a place where they can reach out to you. They feel secure, even if it is to say just hello. So many people call me to just ask me, ma'am, khana kha liya? Aapne kya khaya? And that's all they want to know. That just makes them feel very happy. And a place where you can reach without judgment. So the WhatsApp groups, I think, work beautifully in that manner. We have 50-50-50 related 25 WhatsApp groups. Essential investigation not to be missed out. Absolutely a must keep a record. All of them can be done. Not a single child in Udan is left behind. All the recommended investigations are done. Camps, farmer support, negotiation with labs at a very low price, using government setups in every way, but not a single child. We have a master chart, we see to it, 3 months have happened, HbA1c hua ki nahi, UACR hua ya nahi, thyroid hua ya nahi, everything is done. And we just have to find a source, there's a way to do it. Cannot leave that behind. Helplines are literally life-saving. So these are the helplines that are displayed there. We have 4 helplines. They have made a huge difference. Hospitalization is definitely zero, but the mental health, you get a panic attack. There's an emotional aspect, social aspects. So we train them, give them some investor. We have a record system and we have an evaluation system. That's very important. Anything you do, you have to record, you have to evaluate. That's the only way you will improve and see whether it makes a difference. And last but not least is advocacy. How do we go from an NGO in Udan, in Maharashtra, to have something in the entire country, to join hands with Dr. Sujoy, like government hospital, which will make it sustainable? So how can we make both the worlds come together? Because ultimately, when this will happen in a district hospital, or it will happen in a PHC in Maharashtra, that's when the dream will come true, right? Absolutely, I know that is my final goal. But it works mostly, whatever we have been able to do today, is when children themselves spoke out. So make them the heroes that they deserve to be. Let them walk, let them talk to the government, let them be in the front of whichever program you lead, because it's their life, their mission. And when they speak, it makes the most impact to their lives as well as the outcomes that we desire. So this is my last slide. I just wanted to, this is endless to go on, but I wanted to share some of the small steps which have made a difference in low resource setting care. Thank you so much.
Thank you very much, Dr. Archana Sara, ma'am. I'll just have one liner to this. Whether it's a resource limited setting or a resource abundant setting, the simplicity with which you portray the management of type 1 diabetes, I would say you do not need much resources to manage T1D with the best and the best of the standards of care. You need the best of the intent. You need to be motivated. You need to motivate others. And I'll take that one liner from your slide. Improvise, do not compromise. Thank you once again. Thank you very much. And so, you folks, we had 2 very interesting sessions. Of course, the first one by Dr. Sujoy Ghosh was an amazing lead, a landmark project, something to really take away and implement in the rest of the country and, of course, in the rest of the world. And a lot of inspiration coming in there from Dr. Archana Sada, as always. So what we'll do is we'll have a couple of questions to each of them. I'm sure we have Dr. Banisha is joined here with us, also one of our founder members and Empower T1D. She could come in with any questions, as well as some questions could come in from our audience as well. Dr. Shuja, I'll go to you first with a question. First of all, kudos to you for bringing everybody on the same side of the table and being in the public health sector. I really understand that challenges that you could have gone through, bringing the policymakers, the stakeholders, The doctors who are working in the ground level, they're already burdened with their own work in the district hospital, the nurses, then aligning them to a specific clinic which requires dedication and a lot of intent and motivation. So, besides the science and the data that we understand, your personal experience in bringing all this together, the kind of limitations that you felt could be there, and the acceptance level that you experienced.
See, the first thing I would say is I have an advantage. I work in a government hospital. So for man to get into a government setup and making people work is going to be even more difficult. Let us first accept that. The
Yes.
second thing is because I work in a tertiary care hospital where all the bureaucrats and where all the politicians come is an advantage. By God's grace, a lot of them have diabetes. So I've kind of utilized my personal contacts with these people to make sure that I don't need any personal favors. All that I'm asking for is your help, that you allow me to go and do this. That's number one. Number two, one of the things that you have stated very correctly is the people that are actually delivering the service
Yes.
are usually not motivated. You've got 25 national health programs going on. Everybody is overburdened. Nobody wants to do the job. So I have actually done a lot of background work in each of the districts and figured out the named human resources that I wanted. I knew that these are the ones who are more motivated, because I think one word is needed, and that would have come out in Archana ma'am's presentation: passion, passion, and passion. Nothing else is needed. Somebody needs to be passionate about type 1 diabetes. And the way I've tried to sell it to these people is, if you can manage type 1 diabetes, you can manage any kind of diabetes. And if you can manage diabetes, you can do anything in medicine. Just like when we were students, we were taught manage tuberculosis and you will learn medicine. I'm telling you, manage type 1 diabetes, you will learn anything. So you tell them, you know this, you are miles ahead in your private practice as well. So that's lesson number two. Lesson number three, it has to be a named individual in the clinic. Otherwise, क्या होता है India में? You have a hypertension clinic or something like that. This week, person A is going there. Next week, person B is going there. The week thereafter, person C. Nobody has accountability. So I've made everybody accountable. And once we've managed to establish that setup, I have taken 10 steps back and I have promoted these guys to say, you go out in the district, you are the champions, you are the ones who are doing this. Let them feel that this is their baby, that they are wanted. And I've never tried to be like my senior professors, you know. I'm at their level. ये नहीं कि बाहर से कोई आ रहा है यूनिवर्सिटी हॉस्पिटल से और कह रहा है कि ये कीजिए. If you can keep that stature, saying that, you know, I'm just one of your friends, I am nothing above you, this is your data, you present your data, you present your cases, then it makes, even in the government setup, me more acceptable to them rather than me coming from a high pedestal. This is also very important. Now, the moment those local kids and their families feel that they are wanted in that clinic, they are loved by them in their clinic, not shooed away like in the government hospitals that people normally tend to do, they feel happy about the clinic. And, you know, as healthcare professionals working in a government hospital, we also like being appreciated. So the people working in that particular clinic compared to the rest of the hospital, once they see a group of people who are actually bonding with them, it actually makes them want to work in that clinic. People say, nee, because this year I'll tell you, there's only one day during the Durga Puja that the OPD remains closed. That's Ashtomi. You know that. So most of our clinics in the state are on Thursday, which was Ashtomi this year. But we kept the clinic open and nobody grumbled about it. Because I made everybody realize that 1 week अगर किसी का insulin supply नहीं मिला तो वो मर जाएंगे. So they were motivated themselves in spite of having Durga Puja. Nobody even asked me. They lovingly came to say, no, this is my puja. This is what I enjoy doing. And let me tell you, you know, you've got so many people who look after diabetes in India, right? Adults and young, members of RSSDI, members of Endocrine Society, everybody. Trust me, everybody takes pride in managing type 1 diabetes.
Yes.
You might have seen 500 type 2 diabetes in the last 1 week. But if you've looked after 5 children with type 1 diabetes, you take pride and you say, I I'm a upper level type diabetes specialist. It gives you that pride. So you got to figure out ways and means how you can make people work better in the given circumstances, not making them feel that you burden them, but given them the opportunity to actually enrich their skills, help these children, and feel that they are wanted by those kids as well.
I mean, it's fantastic. It's so inspirational. I mean, bringing everybody together on the same page, and in a way, helping them make a difference. In a way, also feel that that is kind of an incentive to them. That
So
is that they're getting an
I
opportunity.
think one of the things Dr. Archana was talking about was that these children having different kinds of problems. If I'm allowed to share, I actually skipped one slide. Just give me 1 second.
Yes, 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 please.
This is a Father's Day message from a child with type 1 diabetes.
Right.
So there are two images you can see. I don't know whether you can see the images.
Yes, yes.
The first one on the left is from a girl who I saved during type 1 diabetes. She got diagnosed with diabetic ketoacidosis. She's actually drawn this. That's me in that wings. She perhaps thinks that I'm an angel of some sorts, preventing her from the devil taking her away. A single image like that, brightens
Yes,
your life. And the one on the right is a Father's Day message from another girl. Like ma'am said, there are so many people who are struggling with their families. This is relatively well to do off because she's actually written in English. This is a Father's Day post. She writes, got overwhelmed by all the posts of Father's Day. Though I knew it very clearly that you don't like to show off, but I'm genuinely grateful. That's why I'm writing this message. Thank you, Uncle, for being a father figure to me, to bless me with all the love and guidance that I was surely deprived of. Thank you for staying by my side even when I was lost. Thank you for showing me the right track and have faith in me even when everyone lost it. Thank you for inspiring me all throughout this year and especially to accept diabetes as a boon just because of the fact that I'll translate that bit of Bengali, that without that, I would have never known you. Happy Father's Day, Uncle, from your most naughty girl that you've probably met in your lifetime. Things like this keep us going. I think ma'am will agree. What
yes.
money cannot buy this. Trust me.
This is something
I
what
will
makes us feel
totally agree. I will totally agree. And all people in type 1 space agree, and to the extent that my biological kids are so jealous of all my Udan kids because they say you love them more and they give you more love. But I would just like to say what Dr. Sujoy said on a very important note on the team building, whether it's a government setup or a private setup. It's the initial part which is a struggle, but later on, it is very true that they themselves get so joy out of it. And as Dr. Sujoy gave the example, same way, I don't see my team taking a leave. Sometimes they take a leave for a particular festival or something, and they go home and then they miss the work so much, they come back. I mean, if they will just not take, they'll finish the work in 1 hour and come back. So even if they're not well, they'll take medicines, but they will not miss working for children with diabetes. Even in the government medical college here, although we have not yet made headway to the level as Dr. Sujoy said, not being there, we are seen as outsiders. But some of the nursing staff, some of the class 4 staff, some lecturers, some residents have now become part of our family. And they find a way of slipping the child into care and sending them to us, even in their own systems, or trying to do what we have been training them to do. So I think it's a very gratifying, and that's why people work together once they start. For
fantastic.
everyone.
Ma'am, another very interesting observation which I found in Dr. Ghosh's presentation, and I'll try to highlight this. I mean, it's amazing to see that 100% of these kids are on basal bolus. And there was even if there was somebody on pre-mixed, they were switched to the state-of-the-art regime
Absolutely.
that they're supposed to be there. Dr. Ghosh, I have a question to you. You mentioned that there was a significant improvement in their cost of the treatment from where they started initially and then after 1 year. What was the primary reason that you feel in the reduction in the cost of the treatment,
See,
the highlighting practice?
basically, before we had the model, people would have to actually spend out of their pockets.
Hmm.
They were not being provided the insulin for free. Even if they got some supplies from hospitals now and then, it would not be a continuous supply.
Right.
They were not
Structure
given,
supply.
they were not given strips adequately. They were having to do the tests themselves. And now imagine a kid living in Murshidabad. What is the cost of transport of coming from Murshidabad to Kolkata? It's an overnight train. The father is having to bring the child over. A day's working day is lost. So direct and indirect costs were all there. People were getting hospitalized because of ketosis. People were
Yes.
getting hospitalized because of a severe hypoglycemia. So from there, if you have a clinic which is close to your house relatively, so that 400 rupees or so, which the individual is spending every month at the end of the model, is cost of having lost the working for that one day. एक दिन
Or
काम नहीं किया
travel.
तो पैसा नहीं मिलेगा. So we factored in that money that person has lost in having to bring the
Right.
kid. Now what we have now tried to do is we have tried to group people. ये
Mm.
चार बच्चे एक ही मम्मी के साथ आएंगे in the neighborhood if they are staying. Then they are coming once a month. So the second year cost, I'm assuming, is going to go down even more because of this. Because we tried to say, okay, you five, you club together. You are coming from the same village. Why are all five moms coming together? You can cut down if there's an issue. So things like that. We now the challenge that I am facing is, let me be very frank. See, from 5 districts, I had better control. Now from there to go to 10,
Get more diverse.
12 more, I will have 27 in my state. Now you need to figure out who is that person in every state, at least one person with the same fire and passion, who will compromise his own practice, who will compromise his own time, because it's nobody's priority. The government hospital that where you are working, they will not say कि आपको ये काम नहीं करना चाहिए, आप वो सिर्फ वो जाके कीजिए, वो होगा नहीं. Your family doesn't bother about it. Your private practice, if you are practicing, that time is gone. I'll give you an example. Just before the pujas, I went to Midnapur Medical College. That's where the Mednipur West District Clinic is going to be established. It took me 7.5 hours to come back. What normally takes 2.5 hours. So 1.5 days gone. आना में जाना में और उसके बाद preload afterload तो छोड़ ही दीजिए hospital में. So you need somebody in every state to drive this, and to reach Dr. Archana's model in every state and every district. I'm not very sure I will see that before my death, but I hope I will.
We'll
At
bring
least
it.
that's some.
So
कुछ
I
तो
think
हो.
I feel why the both models can come together is once, the main incentive of getting the supplies is there.
Yes.
Now, what is the incentive for monitoring? See, I've given 100 strips, but are the 100 strips being used? Then
Right.
doing correctly and then taking action. Now, obviously, you're getting very good results now, and we did so earlier as well. But then we learned that in spite of giving basal bolus, in spite of giving strips, later on, complacency sets in. ये तो
Yes.
free में मिलता है, that
Yes,
becomes a
exactly.
separate thing, and gradually results start going down. After the initial high, gratitude, happiness, then everything just becomes like it's our right to get it. The government is
Exactly.
giving it to us. And
I
that
think
is when we need to do all these other 25 things. Unless
right.
and until we keep, doing that. So we didn't do this as a big plan. I never knew how to set up an NGO or something.
We need to
We
clone you.
faced those problems,
We need to clone
then
you.
created a solution, then another problem, then another solution. And finally, we had to go towards psychological well-being. So things actually become worse with time because of your kids will become teenagers, they'll have a will of their own. All that is going to happen, right? And then as that happens, challenges will have to be handled beyond supplies and doctors. So what I feel is if because we have learned the hard way, I would love to join hands and, create those systems before you end up having the trouble we had. It's a natural progression of what happens anyway.
Ma'am, this way of incentivizing them with the reward, I mean, we could actually use this process of gamification. I think that can actually be, done in a structured way, that they should earn it. And you rightly said that sometimes when they get it so easily, they become very, very complacent. And one other observation from what Dr. Sujay said is that this whole way of bringing down the cost and clubbing these patients together coming from one single place, I think all this was possible because the maintenance of the data repository and maintenance of the registry and the
Absolutely.
directory, the oversight that you get when you enter the data points, I think that is fantastic. I mean,
Huge, it makes a difference.
yes, big benefit. And if this can be continued, and if we can translate this to a larger scale in more districts, especially in West Bengal, and of course, Dr. Sujay, if there's any way we could contribute, being in the same state in any way, we would love to take part in this initiative, and of course, translate that across in other parts of
But
the
we are
country.
willing to contribute from other states also,
Yes, of
always.
course.
So, but the data documentation of that kind, of course, is essential, 100%, because that's
Absolutely.
how we learn and
It
have
gives you so
outcomes.
much of
But
insights, so much of
but
insights.
other than that, and I learned it the hard way, but there's also some soft data keeping. So we
Yeah,
have a box, which is a secret box, which is written, this will be open only by Dr. Archana. Okay. So that is
right.
where people put in their secret thoughts.
All
Right?
right.
So such data keeping is also very interesting because they will have some complaints, some suggestions, some real life stories which cannot be addressed otherwise. So all kinds of things. Some I think try it, Dr. Sujoy. You might get some
I have
very
something.
interesting
I have something
letters.
very different. From the healthcare
Mm,
professionals. I've kept a
mm,
diary where
mm.
the diary is named lessons learned.
Lessons learned.
So I think I
But that's
made.
official, right? So we
So
want
let's.
something secret also.
No, that's fine. You remember I made a presentation on glycemic control.
Yes,
SLP.
yes.
That's
Mm.
entirely from that lessons learned.
From that diary, yes.
So people, something that you never expected, something that
Mm.
taught you something new. So we told people that you please write down what you learned new while seeing patients today.
So I think Dr. Sujoy and I both are saying one important thing, that documentation is very important. Like my team also has a diary. We don't call it lessons learned, but they will note down, do the recall, make a summary, what went wrong, what could have been better. And they have to submit at the end of the day, every day. And Monday is only maintenance day. पूरे हफ्ते में क्या हुआ is rechecked, reevaluated, thought. Put it in a place and then acted upon for the next week. So that's how it works. And that part, evaluation, looking back, seeking back, learning, recreating is a very important breather needed. So that's something we should add to our supply wherever we are.
And also, that brings to another very important question. And I think this question is coming from one of our viewers. I would like the opinions of both. The question is that any survey or data on comparing the effectiveness between the regular and the rapid analog insulins, as to the quality of the insulins and the better insulins that can be provided to T1Ds through public private health setups, that is to convince the policymakers. Any thoughts, Dr. Ghosh, Dr. Archana?
Right. I'll answer that in three parts.
Yeah.
The first is, now, if you're thinking of a national health policy, only those things should be there on the list which are there on the essential drug list. Otherwise,
Right.
what happens is, when it comes to implementation, say, for example, I tell you that degludec should be given as the basal amyl. I'm just saying this purposefully. I'm
Right.
not talking about the regular and the rapid acting analogs. Now, it's not there on the essential drug list. So some states will straight away say, it's not on the essential drug list, I'm not going to include it. So remember, human regular insulin is on the essential drug list.
Right.
None of the rapid acting analogs are on the national essential drug list. So from a policymaker's point of view, when it comes to health policy implementation, this becomes a problem. The good bit is I have actually pushed for the rapid acting analogs to be in the national health essential drug list. I have done that. It has not gone through. And what I'm telling you is, in the national guideline that will come out, you will have human regular / analog rapid acting insulin without mentioning which rapid acting.
Sure.
Now, if you now ask me about the science of things, I will quote only one meta-analysis, the Cochrane database. The Cochrane database says there is no difference between the two. And I will not get into a fight, because we all have our own personal experiences that the rapid acting analogs might be better. Actually, in children, it might be better. The Cochrane database does not analyze a lot of things of them. It does not analyze, is the child going to eat? What's the tantrum of the child? Might not eat. Therefore, giving the injection a long time before and then the child deciding not to eat might be a major issue. Particularly in situations where the patient is in hospital and you are, आप देखते हैं the trolley आ गया है, nurse is giving the injection and then the food is given. There, the rapid acting analog might be better in a lot.
Absolutely.
More importantly, 40 IU, 100 IU confusion nahi hoga.
That's so true.
To me, the most important thing.
Most important. I agree.
Because if you are
So I will
using,
just add I will add one thing to what Dr. Suresh. I totally agree with him. So it's open what one wants to think. But similar to him, anecdotally, where we found because of resources we were using, we're still using regular, but also maybe by choice. But where by choice we insisted on rapid is one is small children, as Dr. Sujoy said. So them we are definitely using rapid for all of them. And another thing which helped, a big difference it made, was using rapid insulin in school. Because in schools, what was happening was waiting for half an hour before the tiffin, predictability of the meal being there, and all that, and having played, hypoglycemia chances were more with a regular. Because of the environment in school and the situation, we found the compliance to take insulin in school increased dramatically by making the school insulin a rapid insulin. So many, or rather most, or rather all, now all, it used to be many, now all the children in Udan receive a rapid acting insulin for school. Rest of that they take regular, but for school they use a rapid. So
I think this is a
that
very
has really
practical.
helped us.
Ma'am,
Yeah,
just
it's a
It
very
just
has really helped
yes,
us. It has
just a
increased the
query.
use.
Like,
Dr. Manisha.
thank you for the phenomenal presentation. I was like speechless completely, and being listening from the stalwarts has motivated me so much. Thank you so much. Just to add, asking just for my query, like as you said, the rapid acting can be given during the lunchtime. So can we give like regular insulin in the morning or the night and rapid in the lunch? Won't
Yes.
this
Yes,
confuse?
absolutely, absolutely.
why not?
So
You
like
can give another rapid in the evening
as per the
also.
onset of
Regular
the
rapid.
okay.
Yeah.
So like for the
I,
tea
I, I
time, again
usually
one
try,
rapid and then the
I
regular
Yes,
usually
yes.
try to
See the action profile.
right?
Create a sort of a slide, you have the basal and you have the basal, the action profile. Where is the tail going? Where is it going?
That's it.
You just don't want overlaps, and physiologically it makes sense.
Yeah, that sounds
You have to
like
see the timing. If
perfect.
the tiffin is 2 hours after your morning breakfast, then you're not going to give rapid, right? So what time is the tiffin in the school? When
Yeah,
is the lunch time? If tiffin is at 12, coming home, they're having another lunch at 2. Then again, you have to see that time, yeah? But see the pharmacokinetic, it works beautiful. See the action profile.
that's a
I
practical.
think that is a very, very practical question.
Very
Dr. Ghosh
practical.
Dr. Ghosh was sharing your
one of the things that I have often, depending on how much insulin the child is needing every month, that is a major issue. Because, you've got a 3 ml cartridge or you've got a vial. Now, if the child is requiring too little of insulin, the actual regulation tells you once you open the vial, you should not be using it more than 4 weeks in some of them, 6 weeks in some of the insulin. Now, if you are needing, say, 6 units only, then that vial will not finish. Because what I tend to do is I ask them to keep the school wala insulin in school itself, not bring it home or not take it and go back and forth. But all of that depends upon the dose that the child is taking, and sometimes we are permissive in allowing them to waste that, the extra leftover. That is something that we have to also think of. Now, I know this program is sponsored by USB, and I have vested interests in telling USB two things. Number one, Novo is moving out of the insulin business. If you guys do not step in now and help India, whether Biocon or whether other companies, India will be in a mess. Whether it's business for type 1 or type 2, please concentrate on your insulin. और बाकी जो insulin आने वाला है उसको जल्दी लाइए. That's number one.
Absolutely.
Number two, please have something in your hearts for these children with type 1 diabetes. Make sure you bring the junior quick pen, which has a titration of 0.5 units.
Absolutely.
Because children will need those pens. Please forget about business or money earning from those endeavors. But please make it a point you have 0.5 titration for insulin in your pens for children. That will be your contribution to society and the nation. उसमें से zero profit करके वो रखिए. Pens with 0.5 unit titration for every child in India is something that I would request with all the hands to USB.
There's only one company that's available today, and that's what we are using for our small children. And we desperately needed it, so we had to buy it. We had no choice because they do need that titration.
So I think we had a fantastic need of the hour session. It was very, very practical. We spoke about some fantastic learnings and some reality based understanding, and most importantly the collaboration. It did show the intent that we all share from Empower T1D, from Tie Up, from leaders like Dr. Ghosh, Dr. Archana, and from our friends in the USV, with the right intent, getting all of us motivated, motivating one another. And the end of the day, I'll again take that one liner: we have to improvise and not compromise. But once again, a big thank you from my side, from the Empower team, to Dr. Ghosh for joining us, sharing your insight. It was a fantastic presentation. Dr. Archana, as always, kind of a guide to all of us, a person who has been mentoring so many T1D kids, T1D advocates, and even doctors and clinicians across the country, inspiring them to take care of type 1 diabetes. Thank you for all the efforts that you put in. Big thank you to all our members of the Empower T1D and Tie Up group. And I learned that we had about more than 250 doctors and members across the country listening to this event and who had joined us live. Thank you everyone for joining in. And of course, last but not the least, Team USB for supporting this initiative of Empower T1D, bringing everybody on this common knowledge platform as we all share this vision from Empower, bring everybody on the one side of the table, whether it's an individual with diabetes or it's a senior clinician or as a doctor who is specialized in T1D care. Thank you once again very much. But for the last words, I'm really happy that we have Mr. Sachin and Mr. Smito joining in from the USB team. So I will hand it over to them for the closing comments. And once again, thank you everyone for joining in. Mr. Sachin or Mr. Smito?
Thank you, Amit. Can I just squeeze in a word?
Yes.
7th and 8th of December is
Of
Tie Up.
course, yes.
It's a national type 1 diabetes meet in the country, meant for 3 groups, which is doctors treating type 1 diabetes, clinicians, whoever you are, educators, nutritionists who are working in that space, and all groups and people living with type 1 diabetes. So it's a tripatriate, a family of people whose lives are touched with type 1 diabetes coming together. Empower T1D is our partner for this conference. And it's not just a conference, it's a meeting, it's a workshop, it's networking, it's learning with a very good international, national faculty. So I appeal to all of you, 7th and 8th of December, join in Jaipur, and do register, do come. If you have any queries, you have any doubts, you can message us, talk to us, we can help you register. So sorry for taking your time. Over to you.
Thank you very much for bringing that up. I missed that part, but that's how we complement each other in a community. Thank you very much. And once again, I'll request everyone to join us at this tie-up event in December. Please register. We'll share out the registration link, and all our T1D advocates and T1D community leaders is going to be there, and we will take this forward. Thank you very much for joining us. Over to Mr. Sachin or Mr. Smith.
Thank you, sir, madam. Actually, I'm very emotional, like to have these stories. It's a kind of, though my mind was listening, but it was straight, heart was reacting. So it's a kind of a relation between the heart and mind. I request my colleague, Mr. Smito, to take it ahead, please. But thank you so much. A lot of learnings.
Thank you, everybody. And I think one of my greatest, blessing has been that when I started the journey in the insulin sales and marketing is coming close to advocates like you, I think T1, and getting to know T1 better and getting to know that I connected with one word in English called meliorism, which says that the world will be a better place tomorrow if human beings have a positive intent. And I think all of you are proving that. So with that, a big thank you to all of you.
Thank you. Thank you very much, everyone, for joining in. Thank you. Good night. Bye-bye.
Good night. Thank you so much, ma'am.
Thank you so much. Thank you, Amit. Thank you, Amit. Bye, Dr. Sujay.